It's time for the 3-question warm-up for Endocrine 3. Let's get going. An aphasic patient has great trouble producing words but understands everything you say. What type of aphasia does he most likely have? That's going to be Broca's aphasia. Next, what would you see in a patient on physical exam that has a cholesteatoma? So you're going to see this grayish, white, pearly lesion behind the TM or involving the tympanic membrane. Next, which antidepressant is preferred in the treatment of depression with comorbid neuropathic pain? So you might want to use something like duloxetine. All right, that brings us to the end of the warm-up. Let's get to that video.
In this video, we're going to talk about insulin therapy. Both type 1 and type 2 diabetes can be treated with insulin. And which type of diabetes did we say has to be treated with insulin? Type 1. So this lecture is focused more on using insulin for type 1 because they are more sensitive to insulin. The different types of insulin and their durations of action are really important. You don't always have to be so careful with patients with type 2 diabetes who can sometimes use only one kind of insulin and not have 100% time covered, although they can be treated with these types of regimens as well. So on page 110 under the treatment for type 1 diabetes, it says that we can treat with scheduled insulin injections, which is by far the most common, or sometimes use a continuous subcutaneous insulin infusion with an insulin pump. As a side note, why do we have to give insulin as an injection? Why not an insulin pill? Because insulin is a polypeptide or a protein, and when you give a polypeptide orally, it just gets digested and broken down into amino acids before it can be absorbed. So we have to give insulin parenterally. It also includes monitoring of serum glucose at home. Any patient who's on insulin needs to be monitoring their blood sugar fairly frequently. With type 1 diabetes, people are giving insulin for a few reasons. There's a once or twice daily basal insulin. I think of this as the insulin that processes or moves the glucose that's around all the time, like the glucose the liver makes. This dose is usually pretty steady day to day once people figure out what they need. Then there's a food insulin as well, which changes as much as people's food choices change. And with the food insulin, people are going to adjust the insulin for a couple of things. First, their food choices, specifically the number of carb grams, and second, how high the sugar is when the insulin is due. So in other words, they give insulin to process the sugar coming in via carbs and also to bring down the sugar to normal if they're starting too high. A third consideration on the food insulin, which is occasional for some, is exercise, because exercise will lower the glucose. The interesting thing about exercise is that when someone's exercising heavily, the body can use glucose even without insulin. It's like the body is willing to bend its own rules for the sake of having fuel to exercise. Anyway, sometimes people will see the sugar drop when they exercise for this reason, even if they haven't given too much insulin. So a person with type 1 diabetes who's getting ready to exercise, especially if it's been a while since they've exercised and they don't have experience with their body's reaction, needs to check the blood sugar before exercise. If it's going to be prolonged exercise, they should consider checking the blood sugar about every hour while they're exercising to make sure the sugar's not dropping. And they need to check the sugar when they finish exercising. Sometimes the symptoms of exercise, like heart racing and sweating, can be similar to the symptoms of hypoglycemia, which can make it a little more complicated to detect. So if at any time during or after exercise the sugar is too low, the person can have a snack to raise the blood sugar, especially if the goal is to try to keep going with the exercise. Sometimes a little snack before exercise can help. It's a little easier for people on insulin pumps who can just turn down the infusion rate during exercise, or in some cases turn the pump off for a while. So let's talk about formulations of insulin. There are lots of different types and formulations of insulin, so let's talk about how they work and how you use them. Table 5.2 covers the most commonly used insulin preparations, but first I want you to notice that the details here are not bolded. The exact times and durations of actions are not as important as the overall concepts, which insulins are used for what, and how people usually give them. So at the top of the chart there, you have the very rapid-acting insulins, which I sometimes call the analogs, Lispro, Aspart, and glulisine. These are the fastest insulins out there, and they're used in the food and correction insulin category because of this flexibility. They reach their peak effect in about an hour or less, and their duration of action is up to 4 hours. So they start working very quickly, and they wear off very quickly, which makes them ideal for things that change often, like what the blood sugar is and what kind of dinner you feel like having tonight. Regular insulin is next. Its utility in diabetes management is similar to the analogs we just discussed, except it's not quite as fast. It's an older kind of insulin preparation, essentially bioequivalent to the natural human insulin. It has its peak effect at 4 hours and the duration of action up to 8. We use it often for people who need the mealtime insulin but can't afford the more rapid analogs. Then there's NPH insulin, which is formulated to have a longer duration of action, somewhere around 12 to 24 hours. This one is used mostly as a basal insulin, although it does have a peak and ends up being kind of a mix with usefulness. You wouldn't want to use it specifically for each meal like you can do with the regular or the analogs, but it can sometimes be given with breakfast, with some regular, and then the NPH will peak around lunch. So it's also old, it's cheap, so pretty useful for people on a limited budget. And then there's the long-acting insulins, glargine and detamir. These are the mostly flat basal insulins that can be given once daily for glargine and twice daily for detamir. So take note at the bottom of the table which types of insulin are appropriate for use in an insulin pump. Occasionally regular, but most often the rapid-acting analogs. You can use either one. Likewise, when you're treating diabetic ketoacidosis, you're going to use an IV insulin infusion. Sometimes we call this an insulin drip. And you want to use the same insulin, either the rapid insulins, the analogs, or more commonly just the regular insulin. So that's an important point to keep in mind, very high yield. The idea is that these insulins are flexible and quickly out of the system. So you would have a hard time making meaningful adjustments to IV insulin if the infused insulin just sat in the body for 24 hours. So we also need to talk about some different insulin regimens. I've mentioned this a little so far with talk about basal and food insulins. Sometimes we call the food insulin bolus insulin, as in a big slug of insulin that's being given at once. So flip back to figure 5.1, and we're going to look at some different ways of using insulin. Basically, you're trying to mimic normal insulin physiology, keep the sugar from getting too high after you eat, and keep it from getting too low between meals or overnight. I'm sure you're somewhat familiar with this from your third-year rotations. So let's start with the middle graph labeled B. This is an old way to do insulin, and I've worked places where this was all we had to work with. It does work well for people with pretty regular eating schedules. This patient is getting 3 shots of regular insulin every day, one with breakfast, one with lunch, and one with dinner or supper, the evening meal. And then they get 1 shot of the intermediate-acting NPH insulin at bedtime, which carries them through the night. This is not a pure kind of basal bolus regimen like you see with the other types of insulin, since the regular provides some of the basal coverage during the day. But like I said, this really is the poor man's basal bolus insulin because both regular and NPH are inexpensive, and it works okay. But it isn't perfect, especially for people who don't wake up and eat at the same times every day. So look at the graph above that, the one labeled A. This is slightly more physiologic, at least in terms of the basal insulin. Here you get a shot of NPH at bedtime, you get a shot of NPH at breakfast, so that provides a more sustained basal insulin. And then you get regular insulin at breakfast and dinner, so it's still 4 shots of insulin a day. Or you might move that evening dose of NPH to supper time instead of bedtime to keep the basal insulin from dropping off too much. Personally, I prefer to leave it at bedtime. Or sometimes you'll use a rapid-acting insulin for the boluses if you're giving the NPH twice a day, which gives a shorter, tighter spike of insulin with mealtime, which mimics normal physiology a little more closely. So what you're seeing is that there's lots of room to be creative and to tailor the insulin regimen to your patient's needs, particularly with respect to flexibility in the schedule. And then the insulin regimen that's really considered the best, the most physiologic, is graph C. This one is the easiest to manipulate for schedule differences because you're not counting on the bolus insulin for any of the basal coverage. You can really give the boluses any time. So here in this picture, you're giving 3 boluses of insulin with pretty regular meals using a rapid-acting insulin like Lispro. You can see that those boluses are narrower and steeper, faster onset, shorter duration of action. And instead of using 2 shots of NPH for your basal insulin, you're giving a single dose probably of glargine, the really long-acting insulin. Again, glargine lasts a full 24 hours. Detamir is pretty close. For many people, they don't really have a peak, so they're best at mimicking the true physiologic basal insulin. And even though these are typically given in the evening, they don't have to be. You can give them any time of day, as long as you do it at the same time every day so there's good overlap. So let's talk about how you would adjust the amount of insulin you're giving at each time based on the glucose readings. And before we get into this, I want you to get one concept about insulin. Almost all the insulin is being given proactively. In other words, if I give a shot of Lispro right now because I'm about to eat a sandwich, I'm giving it to prevent the rise in blood sugar you would expect to see from the carbs in the meal. It's very common for people to think the insulin they're giving is just to bring the sugar down, but it's really to keep it from going up. Sort of like you would give a blood pressure medicine medicine every day, even if the blood pressure is normal, because you're trying to keep it from going up. So with that said, you can give extra insulin to bring the sugar down, but you do this in addition to the usual scheduled maintenance insulin.
So let's do a patient profile called hypoglycemic Harry. A 52-year-old man comes to the physician complaining of episodes of hypoglycemia. He has type 1 diabetes, which is managed with insulin. So every morning he takes a dose of MPH and a dose of regular insulin. And then he takes another dose of regular insulin with supper and a dose of MPH insulin at bedtime. He brought a diary of blood glucose readings to review. So for each of the scenarios below, what adjustments to his insulin regimen would be most appropriate to prevent hypoglycemia? So there's hypoglycemia before breakfast, hypoglycemia before lunch, hypoglycemia before supper, or hypoglycemia at bedtime. So Harry here is trying to keep costs down. He's on MPH and regular each morning, regular with supper, MPH at bedtime. So that's 2 shots of MPH and 2 shots of regular insulin each day. And this is good practice for remembering how these insulin preparations work. So let's start with the first scenario here and say he has low fasting blood sugar readings first thing in the morning before breakfast. You might want to pause the video here and try to work out the answer. Okay, so what do you need to change? Well, you need to change the evening MPH dose because that's the insulin that's carrying through all night long. That's the insulin that's still in his system when he wakes up in the morning. So if glucose is too low first thing in the morning, you need to reduce the evening MPH. Now, what happens if the glucose is low at noontime before lunch? What are you going to adjust? Okay, you're going to adjust the breakfast regular insulin, which lasts 4 to 6 hours, because that's the insulin that's doing most of the work through the morning. If the glucose is low before supper, say around 5 or 6 at night before the evening meal, what are you going to adjust there? Well, you're going to adjust the morning NPH, which lasts about 12 hours, because that's doing all the work in the afternoon. The regular from the morning is already done. So as the morning dose of regular has worn off, the NPH is still working. And so if the sugar's getting too low in the late afternoon around supper time, you would want to adjust that morning NPH dose. And then what if he has low glucose at bedtime, say 9 or 10 in the evening? Well, you're going to adjust that supper time regular insulin dose because, again, that's what's working 4 or 5 hours after supper. So if you can remember the general roles of the different insulins and that they're proactive, not retroactive, you should have a pretty easy time with these questions. So that's it for insulin. Pretty short. So pause the video, answer the end of session quiz questions, and then we'll go over them. So first question, which type of insulin is used in continuous infusion insulin pumps in treatment of DKA? Most often rapid-acting analog insulins, or sometimes regular insulin. Next, what must be kept in mind for a type 1 diabetic patient that plans to begin a strenuous exercise program? Just remember that the blood sugar is likely to drop during exercise because the muscles are taking up more glucose for energy independent of the insulin. Patients should always have a readily accessible source of glucose to eat in case of a low, and they should check their glucose before exercising, check it every hour while exercising, and then check it after exercising. Makes me tired to think about exercising for multiple hours. Okay, one more. So let's say you have a patient with type 1 diabetes on basal insulin glargine and mealtime insulin aspart, and you review her home glucose records and see that her fasting morning readings are okay, but her pre-lunch, pre-dinner, and bedtime readings climb across the day. So how would you adjust this insulin regimen? Well, you see the basal insulin is working because the fasting readings are good, but the food insulin, the rapid-acting insulin, which is aspart, is not cutting it. So you increase the doses of aspart with meals. If you were to increase the basal, the glargine, which is long-acting and carrying her through the night, this would cause low sugars overnight. All right, that's it for our lecture on insulin.